Welcome to the Deep Dive. Today we are getting into a massive public health challenge that's often called the silent disease. We're talking about bone fragility.
It sounds quiet, but the impact is anything but.
Exactly. The scope of this problem and, the cost is just absolutely staggering.
It's a profound health issue. We're specifically looking at osteoporosis and osteopenia, and these conditions, they lead directly to fragility fractures.
And these aren't just like minor injuries.
Oh no, these are life-altering events. We're talking broken hips, shattered wrists, painful vertebral compressions. They can really diminish a person's quality of life.
And when you look at the financials, the silence is broken by the sound of money just pouring out of the economy.
The numbers are pretty eye-watering.
We're looking at 2010 figures, so they're probably higher now, but the scale is immense. The U.S. alone, what was it, $17 billion?
$17 billion annually. And in Europe, it was even higher, about $37 billion, just for treating these fractures.
Wow. Think about that. That's just an unbelievable amount of money spent simply because bones are thinning out.
And it's driven by countless individual injuries, each one needing hospitalization, rehab, long-term care. It all adds up.
So our mission today is to cut through that silence. We want to get to the source of how we measure fracture risk and decide on treatment. We're talking about bone mineral density, or BMD.
Right.
We're doing a complete deep dive on the gold standard technology for this, which is dual energy X-ray absorptiometry. You'll hear it called a DXA scan.
Yep, DXA.
We're going to unpack the cellular battle happening inside your bones, how DXA actually works, what the scores mean, and critically, the technical pitfalls that radiologists have to watch out for to make sure you get the right diagnosis.
And we should probably start by defining the conditions we're measuring.
Good idea.
First, you have osteopenia. Think of it as the initial stage. Your bone mineral density is reduced. It's below normal, but it's not quite low enough yet to be called osteoporosis.
And then osteoporosis is the more severe form.
Exactly. That's characterized by very low BMD, diminished bone mass.
Yeah.
And as you said, the key manifestation, the thing we're trying to prevent, is fracture.
And just to give everyone some context, how common is that milder stage osteopenia?
It is incredibly common. Data shows that osteopenia affects 54% of postmenopausal women in the U.S.
54%, so over half.
Over half of that entire demographic is walking around with structurally weaker bones, often with no idea, and they're right on the edge of a high-risk diagnosis.
That context is just vital. Okay, so before we jump into the scanner, the technology, we have to understand what's happening at the cellular level, because bone isn't just a static thing.
Not at all. It's more like a construction site that's open 24/7. Bone is constantly remodeling itself. It's a balance between removing old, damaged tissue and building new, strong tissue.
And there are specific cells for each job, right?
Right. There are three main types. First, you have the osteoclasts.
The clasts.
Think of them as the demolition crew. Their job is to resorb or break down old bone tissue. They use enzymes and hydrogen ions to do that.
Okay, so they're tearing things down. Who's building it back up?
That would be the osteoblasts. They're the construction crew. They form new bone, laying down a collagen scaffold and then depositing minerals into it.
Got it. Demolition and construction.
And then you have the osteocytes. They're the mature cells that get embedded in the matrix. Think of them as the maintenance workers or the site supervisors. They help regulate everything.
So in a healthy person, this is all in perfect balance. When does it start to go wrong?
Well, it's largely governed by hormones and other chemical signals. The system tips into pathology when you have too much resorption, too much demolition, or not enough formation.
So the osteoclasts get too active.
Or the osteoblasts get sluggish, yeah. A classic example is parathyroid hormone, PTH, and vitamin D. Their main job is to keep your blood calcium levels stable. If calcium drops, they basically tell the osteoclasts to break down some bone to release calcium back into the blood.
And what about the hormone? Everyone links to this, especially in women, estrogen.
Estrogen deficiency is a huge driver of bone loss, especially after menopause. Estrogen normally acts like a brake on the demolition crew, on the osteoclasts. When your estrogen levels fall, that brake comes off.
And the demolition crew just goes wild.
They go into overdrive. And the construction crew, the osteoblasts, just can't keep up. It's a cascade.
It's not just hormones, though.
Right. Other things, like glucocorticoids, steroids used in some medications, they're particularly bad for bone. They deliver a double whammy.
How so?
They increase the survival of the demolition crew, the osteoclasts, and they actually encourage the death of the construction crew, the osteoblasts.
Wow, so they're actively sabotaging the whole process.
Exactly. And that's why we have to measure BMD so we can see this happening and intervene.
Okay. That makes the need for precise measurement crystal clear. So what do we do about it? How does DXA fit into the long-term plan?
Well, management is a mix of lifestyle changes. Getting enough calcium and vitamin D, weight-bearing exercise, stopping smoking, and then pharmacotherapy. Yes. The first-line treatment is often a class of drugs called oral bisphosphonates. They're designed specifically to inhibit the osteoclasts, to slow down that demolition crew.
And this isn't a quick fix. We're talking years of treatment.
It's often a 5-year regimen, at least initially, and to decide who needs that treatment, and then to monitor if it's actually working, we need that precise, reliable diagnosis from a DXA scan.
Okay, so let's talk about the machine itself, the DXA. Why is this the gold standard?
The science is really powerful. Basically, the machine passes 2 separate X-ray beams through the part of your body being scanned, usually the hip and the spine.
2 beams. Why 2?
Because there are different energy levels, one high and one low. In your bone, in your soft tissue like muscle and fat, they absorb those beams differently.
I see.
A computer algorithm then looks at the difference in how much of each beam got through, and by doing that, it can mathematically subtract all the soft tissue.
So it just filters everything else out.
Precisely. It strips away everything that isn't mineral. What you're left with is the bone mineral density, or BMD, measured in grams per centimeter squared.
And then that number gets compared to a huge database of other people.
Exactly. And that's why DXA is so dominant over other methods like CT or ultrasound. It has been proven over and over in huge studies to be the best predictor of your actual fracture risk. That's the clinical bottom line.
Plus, it's cheap, fast, and pretty much everywhere.
Yep.
Now, you mentioned X-rays. People hear that and they think about radiation, especially if they need scans every couple of years. What's the dose like?
It's incredibly reassuringly low. A standard DXA scan is about 0.001 millisieverts.
What does that mean in real-world terms?
It means it's about the same amount of background radiation you get just living your life for 3 hours.
Just 3 hours.
Yeah. And if you compare it to, say, a single chest X-ray, the DXA dose is 100 times less. It's so minimal that monitoring studies are completely safe.
That is a huge relief to hear. Okay, let's get into the numbers that lead to the diagnosis. The T-score and the Z-score. The T-score is the big one for older adults.
The T-score is key. It tells you how many standard deviations your BMD is from the average BMD of a healthy young adult at their peak bone mass, which is usually around age 20 to 25.
So you're being compared to a 25-year-old at their strongest.
That's the benchmark, yes. And it's used for diagnosis in postmenopausal women and men over 50.
What are the thresholds we need to know?
Okay, so a T-score of -1 or higher is considered normal. Osteopenia is that middle ground, between -1 and -2.5.
And then the big one.
Once your T-score hits -2.5 or less so, -2.6, -3.0. That is the diagnostic criteria for osteoporosis.
Now, what if you get different scores for your hip and your spine?
Great question. The rule is you always use the lowest T-score for the diagnosis. If your hip is osteopenic but your spine's osteoporotic, you have osteoporosis, period.
You're only as strong as your weakest link. That makes sense. So why do we also have a Z-score?
The Z-score is different. It compares you to an average person of your own age, sex, and ethnicity.
So you're being compared to your peers.
Exactly. And it's recommended for use in children, premenopausal women, and men under 50. In a healthy person, your Z-score shouldn't really change much as you get older because your peer group is aging right along with you.
Okay, beyond just the score, there's a tool that puts it all together, the FRAX tool. Why is that so important?
The Fracture Risk Assessment Tool, FRAX, is essential because it moves us beyond just density. It takes your DXA data, specifically from the femoral neck and your hip, and it combines it with other clinical risk factors.
Like what?
Things like smoking, heavy alcohol use if you've had a fracture before, long-term steroid use, a family history of hip fracture.
And why do those things matter so much?
Well, a previous fracture is the single biggest predictor of a future one. Smoking affects blood supply to the bone. By putting all these real-world factors together, FRAX gives you a personalized 10-year probability of having a major fracture.
So it's a much more complete picture of your actual individual risk.
A far more accurate one than the BMD number alone, yes.
Okay, this is where the real deep dive begins. The pitfalls. This is where the skill of the radiologist is just indispensable. If they just trust the number the machine spits out, where can things go horribly wrong?
The biggest challenge by far in reading lumbar spine scans is degenerative change. Just plain old arthritis.
Arthritis. How does that mess with the scan?
Arthritis causes sclerosis, which is a hardening and an increased density of the bone in the joints. And this can falsely, artificially, raise the BMD calculation.
Wait, so a patient could have weak osteoporotic bones, but the arthritis makes the T-score look normal or even good.
Precisely. It can completely hide the underlying disease. A huge red flag for us is when we see the T-scores differ by more than one full standard deviation between adjacent vertebrae, like L3 and L4.
What do you do then?
That tells us something is wrong. You have to immediately exclude those affected vertebrae from the final calculation. If you don't, you can underdiagnose the patient, and they won't get the treatment they need.
Wow. What else can throw off the numbers? I'm guessing metal.
Metal is a huge one. Any surgical hardware, spinal fusion rods, hip replacements, cement from a vertebroplasty, all of that has to be excluded. It makes the bone look incredibly dense when it's just metal.
So if you have a hip replacement, you just can't scan that hip.
Right. We'd have to rely on the other hip, or sometimes we scan the radius bone in your forearm.
What about things that aren't solid metal? I heard that having another imaging study can be a problem.
Yes, that's a key technical point. If you've had a study with oral barium or IV contrast within the last, say, 10 days, that can hang around in your system.
And it messes up the DXA reading.
It can artificially inflate it. We have to check the patient's recent history, and if they've had contrast, we usually have to reschedule the scan.
The level of detail required is just incredible. And sometimes the error is much simpler. It's just a labeling mistake.
And that can change a patient's life. This is why confirming the anatomy is so critical. We sometimes see cases where the T12 vertebra is mislabeled as L1. It sounds like a small thing.
But it's not.
It's not. In the source material, there's an example where that one simple labeling error changed the patient's T-score from -2.8 to -2.0 after it was corrected.
Whoa! So wait, -2.8 is definitive osteoporosis. That means you need treatment right now. -2.0 is just osteopenia.
It's the difference between getting treatment and not getting treatment. It's a massive clinical consequence, all because the wrong label was put on the wrong bone. The reader has to visually confirm they're looking at the right anatomy every single time.
Okay, one last really crucial special case. Primary hyperparathyroidism. If the standard scans look normal, where do you have to look?
This is a vital detail. For this specific disorder, you must assess the 1/3 radius of the non-dominant forearm, so 33% of the way up the forearm bone.
Why there specifically?
Because that part of the radius is mostly cortical bone, the hard, dense outer layer. And primary hyperparathyroidism preferentially attacks and damages that cortical bone first.
And the spine and hip are mostly the other kind of bone, trabecular bone.
Right. So if you only scan the spine and hip in these patients, you'll miss the damage. You'll underestimate their true fracture risk. You have to look at the radius.
So we've talked a lot about density, which is the quantity, but what about the quality of the bone, the structure?
Yes, this is sort of the next frontier beyond BMD.
Yeah.
There's a tool called the Trabecular Bone Score, or TBS. It's software that analyzes the original spine DXA image.
What does it measure?
It measures the gray level texture of the bone, which gives us an index of the microarchitecture. A low TBS score is linked to a higher fracture risk, and importantly, it's independent of the T-score.
So it's like measuring the quality of the scaffolding inside the bone, not just how thick the walls are.
That's a great way to put it. Its biggest use is for patients who are right on the borderline, where you're not sure whether to start treatment based on their T-score. A bad TBS can tip the scales.
It's fascinating that the DXA machine can also be used for body composition. Is that common?
It's surprisingly good at it. It can measure your total body fat percentage, your lean mass, and even your visceral fat, the dangerous fat around your organs.
So is this becoming standard practice?
Not really for the general population. The ISCD does recommend it for some specific groups like HIV patients or people undergoing bariatric surgery to track changes.
But not for everyone yet.
No, the big problem is that the standardization between machines from different manufacturers is still pretty poor for body composition.
Yeah.
So it's hard to track you over time unless you always use the exact same machine.
Okay, so let's try to summarize this whole deep dive. What are the absolute most critical takeaways for getting an accurate diagnosis?
All right, number one, always base the final diagnosis on the lowest BMD site. If one site shows osteoporosis, the patient has osteoporosis.
And don't just trust the number, look at the image.
Exactly. Number two, actively exclude vertebrae that are affected by arthritis or surgical hardware. If the T-scores between levels are wildly different, investigate.
And number three?
Don't forget the special cases. For suspected hyperparathyroidism, you must use the 33% radius scan to see the real damage.
And finally, look for other things that don't belong.
Always. Scrutinize the images for anything that could be artificially inflating the BMD. That could be calcified fibroids or even something as serious as sclerotic bone metastases from cancer. The scan is not just a number, it's a complex medical image.
That really drives it home. The diagnosis is this combination of technology, anatomy, and clinical history. So we started this talking about how DXA gives us density and tools like TBS give us texture, but the actual disease is this tangled web of hormones and cytokines.
Which leads us to the big question moving forward. We have all this growing evidence about bone quality, not just quantity. So how can the medical community fully integrate all of this information to move beyond these simple thresholds and create truly individualized preventative treatment plans for every single patient, no matter their age or their complexity?
That idea, moving from general guidelines to truly personalized bone care, is a powerful thought for the future. And that is a wrap on our deep dive into bone density and the intricate science of DXA scanning.